All right, let's see here. What's going on, everybody? This is AD Prop Push, and today we are going to be looking at full code medical simulation. So, will be a fun one. I've been trying to find a game like this, but instead what I did is I went to an actual medical website that you can run these simulations for training and stuff like that. And I think it's supposed to be meant for like EMTs, doctors, etc. So let's see what we can do with this. Let's see what the daily patient looks like. Challenge me. Play without hints in our life. Yes, please do. I don't want the hints. I'm going to figure out what's going on with this 71-year-old. All right, patient is a walk-in. Well-appearing 71-year-old female reports abnormal outpatient blood works. No acute symptoms. Interesting. Okay. Let's go ahead and chat with this patient. How are we doing today? I'm feeling really tired today. It's been about 6 months of feeling tired at 71 years old. My primary care provider told me to come in right away because my labs were bad. Uh-oh, somebody's having a heart attack. Potassium level was high, around 6. Holy moly. All right, so one of the first things that we're going to want to do with this is we are definitely going to want to attach a monitor to start out. You can see the super high peaks. Looks like a first degree heart block might be in there. Another one of the things that we're going to really want to be trying to do with something like this is an EKG. So we can see if there's any like heart abnormalities. It looks like, is that AFib? That's AFib. And it looks like she's got a little bit of high peaks with the hyperkalemia, which is typical. So the high peaks is QRSs, these tall waves. They get a little higher with hyperkalemia. I'm gonna go ahead and insert an IV. Let's see here. We're gonna go ahead and examine just because I don't really need to know too much about this, just to make sure everything here is normal. Go ahead and listen to the chest. Irregular rhythms, but no murmurs, no rubs, no gallops. Might as well listen to the lungs. We're already there. Trace scattered wheezing. All right. Well, one of the other things we want to ask. Do you have any allergies? Do you have any past medical history? I have low thyroid, AFib, high blood pressure. So the AFib's not new. Kidney problems, COPD, sleep apnea, and some depression and anxiety. Do you take any medications? Do you have a list of the medications you take at home? Thyroid medication for the thyroid, Eliquis or Bixapan, and digoxin for the AFib, and metoprolol for the AFib, lisinopril for that, albuterol. We could probably actually get her some albuterol now. Fluconazole, mirtazapine. All right, so she doesn't have any history of, oh, she has kidney problems. Let's go ahead and order some lab work. Before we treat anything, we want to definitely get a BMP. We're going to go ahead and get a magnesium level. Why not? Probably don't need it. I don't think any of these other ones are going to be super, super crazy. Let me just look through these, see if there's anything else? I think we're okay with that. Do you have any other symptoms while that's pulling up? Creatinine, okay. Well, just a little fatigue. Potassium's 4.7. Currently. So, it's a good thing we didn't actually treat her at the moment. So, what she said is that her potassium may be around 6. Her creatinine levels just barely high. Honestly, there's not much going on here. She does have the AFib, but I mean, it's a controlled rate. She's already taking medications for that. Let's go ahead and I guess do the rest of this. Everything here looks good. Everything here looks good. You know what? She did have some wheezing in the chest. We can actually go ahead and give her a dose of albuterol to help out with some of the breathing. Let's take a listen to that chest again. Sounds normal again. Soft, non-tender. I don't think I need to check that. CVA. So what probably would have happened is she would have had some like hemolyzed labs. Warm, dry rashes, neuro, normal bug, no drift. Okay. And mildly anxious. Okay. I mean, honestly, I'm kind of... could maybe do some fluids, but at the same time, she's got mild... Hold on. Any changes with your diet? Not really. My diet has been about the same. I mean... about the same. I'm honestly at a loss for words. I don't know what else to do with this. Lab work's all... I mean, like, a little bit of the kidney stuff, but if I remember correctly... You know what? She did say she has the thyroid stuff. I don't need... Uh-huh. Communicate. Consult endocrine. Nope. Evaluating for... yeah, hypothyroidism. I mean, that's basically what I consulted you for. Is there a separate doctor for that? It's not going to be toxicology. We don't need a nephrologist for sure. Consult PCP. Maybe we got the wrong... Thanks for calling. Miss Eriks had a CBC BMP drawn 3 days ago. She was sent in because her potassium result was 7.1. Everything else looked at baseline for her. I'm relieved to hear that her potassium level is normal today. And if there are no other findings, you can have her follow up with me. Oh, okay. Well, everything's fine. I mean, she's already taken the medication for it. So there is nothing else wrong with her. I put an IV in her for nothing. All right. Well, fair enough. What would the differential be? Nothing? Because I didn't see her with hyperkalemia or anything like that. General malaise. Just not feeling well and tired. It has 2 correct diagnoses. Alright, so let's do endocrine. We're going to say hypothyroidism. And then I guess hyperkalemia? I mean, she's not hyperkalemic anymore. Renal labs are very mildly elevated. Could maybe. Yeah, not even any of this. It's yeah. I don't know what even half of this stuff is. That's crazy. Urinary tract infection. I guess genitourinary. Okay, that makes more sense. Let's see. Yeah, I guess let's go with the hyperkalemic. I mean, she's not hyperkalemic anymore. Where's my list of things? There it is. Let me just make sure there's nothing else I want to run. I think we're okay. I don't think so. I really don't. I think we're okay. Discharge, routine, follow-up, and we'll say with these two. No, I think we're good. We got 75. It wasn't hyperkalemia, which, like I said, I didn't think it would. What was the other one, though? Discuss details. You've only played this case one time. Are you sure you want to reveal the answers? I mean, I'd like to know, yeah. What did I do? The patient initially arrived at the emergency department with preliminary diagnosis of hyperkalemia based on outpatient lab results. In addition, she had worse fatigue over the past 6 months, consistent with hypothyroidism, which she did, and we had on there. Hyperkalemia is a life-threatening condition. Yes, I know this. However, the true diagnosis of pseudo-hypokalemia also elevated because of hemolysis. I talked about hemolysis. Wait, was that a diagnosis? Pseudo-hyperkalemia? Is that a diagnosis? That's insane if it is. Could be due to renal failure, which renal stuff, all that good stuff was fine. And she doesn't have hypovolemic medication. She's not on rhabdo. She's not diabetic. Yeah, okay. So largely non-revealing reasons. Suspicion for a possible lab area. That's what I said from the get-go. Suspected lab area. The specimen should be drawn carefully to prevent hemolysis. Yeah. A DIG level. She was on DIG. Digoxin. That's, yeah. I should have. Yeah. That's absolutely right. Reasonable to consider obtaining additional blood tests. I got a CBC to test for anemia, mostly because of the feeling tired, and also if you hemolyze enough cells, it can also raise your potassium levels. Okay, whatever. Next. No, I like it. And with 500 different cases, I'm sure by the time I play it again, I'm not going to remember. Just play a case. I want a random case. 26-year-old male found confused at home. Patient reported fever last night. Family awoke today to find him disoriented. Moving all extremities and field. No verbal response. BP is 118/76. Heart rate 120. Respiratory rate 22. Setting 99% on room air. No events during transport. Patient with acute confusion. Vital stable in field. Directed to resuscitation bay. All right. So what this sounds like to me, mostly because of the fever, is we are dealing with sepsis. He is confused. Oh, what's this? Oh, I don't want to tutor him. Get out of here. Attach the monitor. Let's get that on there. Am I not able to talk to him because he's a little confused? Fair enough. Oh, this one's different. Patient moans, not responding to direct questions. Eyes, not responding to direct questions. Patient moaning, not respond. Okay. There's respiratory. So he's just kind of sitting there and moaning, but he had a fever. He still has a fever. Let's go ahead and get this started. Where are you? Is it under miscellaneous? No. There. Let's go ahead and give that. Try to take care of the fever. We do have a little bit of tachycardia. Just go ahead and get this. Make sure there's nothing going on here. Sinus tach, no ischemic changes. Looking in there, there's no elevated ST waves. Everything is there. It's just a little fast. If we control the fever, we may control the heart rate. One of the other things that we're going to go ahead and order, lab work. We want this. Probably should be fine on that. We're going to go ahead and run one of these, one of these. Let's go ahead and get a Magenfoss just to have it. We want a UA, other labs. I want blood cultures for sure. Yeah, why not? Why not? It's fine. What else do we got there? That's the big one. Let's see what these show. Blood pressure still stable. White counts is definitely elevated. Definitely putting that IV in right now. Oh. Okay. Well, we definitely have C-reactive protein. That's there. He is confused. He's definitely got an infection. Something that I probably really should be looking at is donning personal protective equipment, because I'm thinking we're dealing with something respiratory. I meant to put in something for that, but I actually didn't see the labs when I went through it. Is there no nasal swabs? Could be a virus. There's COVID test. Oh no, somebody's dying. Is that the only thing I got is the COVID test? Is there no other... What about flu? Am I just skipping over them? We're just going to ignore the fact that there's other types of viruses? Alright, whatever. I'll run with what I got. That's negative. Well, shoot. Back to patient. No known alcohol substance use, no reported drug use in the family. He's confused. I mean, he's confused just to make sure we rule it out. I'm not expecting this to come back positive. But let's go ahead and do a CT. It's CTA head neck. There we go. CT, CTA head neck. Just to make sure. Alright, everything here is fine. I mean, I didn't really need the CTA, I guess, but a CT just to make sure there's nothing going on there with confusion. We don't know if he hit his head or anything like that overnight. I just kind of shooting in the dark. He's 26. What else would be causing confusion? He's not able to really talk back. It's not going to be really any of that. Wait a second. Holy crap. There we are. That's what it is, I bet you. He's rubbing his head. He's confused. Did it say anything on his neck exam? It doesn't say anything. Oh, here. Limited range of motions and involuntary. Yep, that's it. Holy crap. I skipped right over that. Okay, what we got is meningitis. So, interventions, procedures. We are going to be doing a lumbar puncture. I guess we can do an image. I guess I didn't realize we had to do an image first. That's weird. CT, head, C-spine, abdomen. There's no x-ray for that, right? X-ray chest. You don't need an MRI. Do we need an MRI? I don't think we do. No, we don't. We don't need an MRI. That's not... Normal. 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 Okay. Now, back to this. I want this done. I've done a lot of extra things to appease you. I will order the test. lab work. I want you to give me everything. Might as well run it because we have it. There it is. Gram-positive cocci in pairs. Okay. It's probably just going to be infectious disease, right? These criteria for sepsis. Try identifying source. For sepsis criteria, yeah. Well, I mean, I guess I could have started this a little earlier, actually. We're going to go ahead and do LR bolus. And then LR infusion. We are going to go ahead. Is there a second IV we can do? Vascular access. Second IV just to have it. And beyond that, we already sent off cultures, right? Blood cultures. We did. Okay, they're processing. Interventions. We're going to go ahead and start antibiotics. And we already determined that there's cocci in there. I'm trying to remember which one does coccis. I'd be lying if I told you I knew exactly which one of these I need to do, but I feel like Zosyn is a good one to start with. And you know what? Let's go ahead and do Rocephin as well, ceftriaxone. Just for SNLs. Alright. Well, differential. We've determined infectious disease. Infection. There. We have determined that he has meningitis. Meningococcemia. And that is going to be droplet precautions with meningococcus. There we go. Finish. Let's say, oh no! It wasn't meningococcemia. That's not good. Review of system. Oh, because I didn't do them all. Patient cannot provide history. Yeah. I mean, examination. What did I not do? Head, ears, nose. Did I not do that? I could have sworn I'd done that. Interventions. Neutral. I did. Also correct. I almost did the bank. Sulfloxin. I thought about doing the acyclovir. I'm not going to lie. All right. Critical. 3 of the 5. Hey, none of the neutrals are there, though, huh? I did Zosyn and ceftriaxone, which honestly should have been fine. We could have done acyclovir as well, just to cover any viral as well. I got a 60 on that, though. Communication. Neutral. I mean... Oh, it's because I didn't get the urine cultures. And I did an unnecessary C-spine. Which, you know. I only did that because it made me. Okay, whatever. Do I have to do that? No, okay. Well, it's a good thing I'm not a doctor. Let's see. Random case. Let's do another one. Hospital, day 2. Very important to note that the time is 04:55. It's really close to shift change. Subjective, 68-year-old, admitted with pyelonephritis on day 2 of ceftriaxone. They've been afebrile overnight. Vomiting has resolved. Held furosemide or Lasix overnight due to concern for AKI and volume losses. Okay. For the vomiting on admission. Neck, pearl, neck, subtle. Lungs clear, regular rate and rhythm. Abdominal soft, minimal. Left CVA tenderness. Left CVA tenderness? Wait, what? What do you mean by CVA? Oh, is this the... Maybe. +1 to the knee. Assess improving on Rocephin. Urine cultures and sensitivity are still pending. Plan is transition to PO antibiotics. Restart Lasix once tolerating oral intake. Last shift noted patient was fine, seemed to be improving. Was able to take PO this morning. When floor nurse came to assess, patient appeared acute, short of breath, started nasal cannula and activated a rapid response. Okay, well, first things first, let's go ahead and make sure that there's a monitor and an IV because we are doing a rapid. Why can't we do an IV? Oh, you already have one. Okay, cool. Thank you. 122. Oh, okay. Oxygen. She's already on the nasal cannula. Non-invasive positive pressure ventilation. I don't know that I want to do that yet. I'm assuming we're maxed out on the oxygen. Let's go ahead and do that. Palm. Coarse airs, diffuse rails throughout. Let's go ahead and imaging, quick chest x-ray. Go. Increasing consistency pulmonary edema. Perfect. Not really, but I know exactly what to do in this situation. Cardiac. We need to get her some. Where's the fuck is the Lasix? You're kidding me. Respiratory? No. It's not gonna be that. Miscellaneous? There. Furosemide, bolus, go. Ooh, that blood pressure high. Alright. Recheck. Let's go ahead and do the other things. Nothing. Tachycardia, regular rhythm. No, remember, no. +4. Okay, so she is going into heart failure. Oh, no! Her sats are not looking great. We may be intubating. Alright, real quick, just to make sure. Bedside test, EKG. Let's get that started. Sinus tach without ischemic changes. EKG's done. Great. I want this. Might as well do that. It's probably gonna be artificially high anyways. We already got that. I don't think it's gonna be that. We're still at 76. Probably gonna have to end up intubating. I don't think we need to do any of this other stuff. Alright, let's run with what we got there. pH 7. Ooh. Oh. O2's low. CO2's actually not too bad. She's got too much bicarb. No, not enough bicarb. It's her kidneys, yeah. But she should be breathing faster than 12. Wait, what? Mag low. Oh, her CO2's low, so I guess I wouldn't drive that too much, but her mag's low up. Very high on that. Let's... How much is in a bolus with the, Why is this not underneath a cardiac medication? Why is it under miscellaneous? And it doesn't seem to have done anything for her whenever we did that either. She's at 75%. This is crap. Okay. I mean, None of that's gonna do anything. Well, I mean, we know that she's volume fluid overloaded. We're gonna console her, I guess, cards. Patient seems to be having a hypertensive crisis, causing acute. Oh, is that all it is? Alright, well, metoprolol bolus as well. I guess I should have treated that blood pressure. I wasn't even looking at that. Let's bring that down. You did do that, right? I mean, it barely touched her blood pressure. Any history? I guess I... Oh, this is one of the ones I could duck to. I can't breathe. Let's just let her talk while she's like trying to breathe. Heart failure, high cholesterol, surgery of the spine, surgery of the colon for cancer. She's a cancer patient, okay. Any allergies? Not that I know of. Alright, we can do that, I guess. See if that does anything. I think... I'm guessing at this point. I'm kind of lost on that one. Trying to bring heart rate down and blood pressure. Gave them Lasix. There's not too many other... I mean, do we have... if that was the paste, I'd be for it. Put her on a nicardipine drip. Oh, there's a labetalol bolus. Let's go for it. I didn't think it would be over there. There we go. I mean, we're getting to a point where we're about to have to intubate either way, because we're not bringing our oxygen up at all with that. I feel like this isn't gonna do it, though. There! That's what she needed. Oh god, what is she doing? Chest pain. Oh crap. Let's do EKG real fast. Another EKG stat. No. EKG's done. Really trouble breathing. She's already settled though, yeah. And I've already given this. What else do you want from me? I mean, there's not really any other procedures I can do. None of those are going to do anything. I already given pretty much all of these. Alright, blood pressure's already looking better. Give her some propofol. I'm just kidding. I'm just kidding. That might be a bit much, right? That'd be rude. She's already breathing 11 a minute. I mean, the only other thing I could think of is some bicarb, which isn't really an option, is it? I'm giving her the kitchen sink right now. I'm just throwing everything at her. I don't think it's going to be in here, is it? If it is, it might be here. Bicarbonate. Because we did it ABG, right? That's one of the very first tests that came back. pH was low. But the CO2 is also a little low. And the only reason it would be low with the other is because there's so bicarb being low. Which it's actually not. Wait, why is your... Oh, wait, hold on. Not work. What's your lactate? No, it's a... Okay. Honestly, you're probably going to be going to the ICU. Cardiac ICU for heart failure. It sounds like. I mean, you're relatively stable, but you got a lot going on with you. No, ain't none of that. What else do we got? It's not going to be this, right? I guess it would. Pulmonary effusion. Acute respiratory distress syndrome. Alright. We already consulted cardiology. Do I need to consult anybody else? And be transferred to the ICU with pulmonary effusion. There's one other test I feel like I really need to do. What is it? It was in my head just a minute ago and then it slipped away. Oh wait, no, it was a medication. But I don't think... not really. Shouldn't be in here. It's not going to be in there. It's not going to be any of those. What am I missing? I guess just tell me. I'm lost for words. Send her off. 31. Wasn't even pleural effusion, huh? Interventions. All of my crap was wrong. Metoprolol, propranolol, labetalol. Negative 100 points. Well, thank you. The furosemide bolus was recommended, and I did do. Critical, though. What was the critical one? What am I missing? Nitroglycerin. But we're on the floor. I didn't know. I thought about doing the nicardipine. I actually hovered over that. That was later. I almost did do that. Stabilization. Non-rebreather mask. Attached monitor. Non-invasive. Yeah. What's the other one? Second IV. Yeah. That's a fair point. Oh, my interventions were absolute trash. And it's because I did a lot of stuff that she didn't need. Okay. That was a big... Wait, hold on. Well, I already missed it. And say, well, what was the actual thing then? Oh, whatever. Let's keep it going. Let's go kill some more people. 44-year-old male with a cough and fever and diarrhea. Stomach bug. It's a lot of things going on there. Patient noted to be ill appearing by clinical staff. Awake, alert, neurologically intact on evaluation. Blood pressure was 136/89. Heart rate 125. Respiratory rate 30 to 35. SpO2 was 91. Placed on a nasal cannula. Stable during transport. Okay. Respiratory rate of 30 to 35 doesn't sound too incredibly stable. If I was being quite frank. 44-year-old male with cough, fever, and diarrhea. Multiple sick contacts in the community. Febrile and hypoxic, directed to isolation room. Well, the very first thing I guess that we should probably be doing is donning our personal protective equipment. Let's go ahead and make sure that we have this and that going. 94 over 62, so he's looking a little, you know. Fever, coughing, dealing with diarrhea, any allergies, any past medical history, high blood pressure and diabetes, any lisinopril, hydrochlorothiazide, metformin. Let's go ahead and treat that fever. Should be good. Started taking metformin a few years ago, so the diarrhea is probably not from that. Alright, well, we're going to go ahead and get that treated. Let's go ahead and, at bare minimum, at least get him started on some fluids. In the meantime, let's run some tests. Oh, hello. Oxygen. I thought you were already on a nasal cannula. I guess not. So we have that. That should help out with some of the breathing. Let's do EKG just to make sure all this looks great. Sinus tac. No sinus. Everything up there looks fabulous, even though it's blurry as can be. All right. Lab works. BMP. CBC. Lactate. Megan Foss. Should need. Go ahead and do a urinalysis. We're going to go ahead and do blood cultures and that. Influenza. I bet you it comes back with influenza. But CRP. Let's go ahead and get a chest x-ray as well. Why count slow? Hold up. Lactate's high. Positive COVID. There it is. Ground glass opacities. Bilateral opacities. Okay. Multifocal pneumonia. COVID-19 infection. There we go. Alright. Well, there we go. Differential. We know what it is. We already got him on fluids. Everything here appears to be mostly stabilized. Let's go ahead and give him a small bolus of fluids. How's our lab work look? Seems good. Chloride's good. We're going to do a normal saline bolus. That'll be fine. Don't freak me out like that. You know what? I forgot to do the ABCs. No stridor, no respiratory distress, +1 peripheral pulse, slightly delayed, which blood pressure soft. That's going to be a little expected. Don't need to do all of these. I do want to check this tachycardic. Okay. Yeah, that's going to be what expected. Palm. Faint rails present. Left, low, and lower long fields. Bilateral. Well. You're going to have a cough. I'm sorry. That's just part of it. Fever's good. Shouldn't need any of these other stuff here. I shouldn't need that. Shouldn't need that. Should be good. Wouldn't he have a diarrhea? I misspelled diarrhea. Holy crap. I don't even know if I have something for that. I don't. I do not. Just to make sure. Those two are in fact negative. Processing. Okay. Dum-dum-dum. Can we run out of the chem? No? Okay. Fair enough. Infectious disease. We have COVID-19. With acute respiratory failure. You could even say sepsis. Acute respiratory distress syndrome. We can go with that. That sounds good to me. Still touch tacky. Blood pressure's looking much better. Still soft, but within a good range. It's got that. I don't think I'm gonna need a hazmat suit unless this thing's still taking place back in COVID era. Like, normal airborne precautions should be fine. I don't need a hazmat suit for this. I don't see where I have to consult anybody else. We can consult infection control, but it's probably... Yeah, he should be, isn't he? I got on PPE. Are you gonna tell me I need this? Oh, snap! I didn't realize... Oh, I thought that was... Y'all said y'all put him in the isolation room. I thought. Thanks, Doc. Almost completely went over my head. Alright. I'm at the floor in isolation. He is on oxygen, where he wasn't. Oh. A third diagnosis? What are you going to say? Sepsis? That's not even an option. Environmental? Oh, shark bite. Is that what that just said? No. Did I even do all the rest of the exams? Warm, dry, no rash, neuro. All that's intact. Shouldn't have to do psych. This should be fine. Back should be fine. That should be fine. I think we're okay. We did do a chest x-ray, did we not? Okay, and it just shows the opacities. Which, clear pneumonia, I guess. Is there something else I'm missing? I mean, I guess we could do an ABG. I don't think it's necessary. It won't kill him, but it's definitely probably... No, yeah, he's great. There's no reason for him to go to ICU. Normal Nasal is doing everything it's supposed to. Blood pressure's fixed. Everything apart from a little bit of tachycardia. Is that what you're wanting me to put as tachycardia? Is that it? Because that's kind of silly. What am I missing? Blood sugar was fine, right? Yeah, all that's great. Everything looks great. Wait, why counts elevated? What differential am I missing? It's not gonna be that. Oh, wait. Hypotension? I mean, that should have been sepsis, though. Underneath sepsis. Is that what we're going for, though? I don't know. Pulmonary. I got this already. What was your other history? High blood pressure and diabetes. Oh, wait, he had some diarrhea. Hold on. Is that something I should be looking into? I mean, to do imaging for diarrhea would be wild. Okay. This is probably completely out there, but... What am I missing? I don't know how I would know if you have C. diff if I can't even test for C. diff. I'll do it. Why not? Just do it. 100%. See, he's doing great. Not that he needed that. I'm gonna start. I'm starting to hurt myself with these labs now. What am I missing? Let's go piss off the pulmonologist. Avoid using non-invasive positive pressure. I know I can't increase fire. Yep. Should be utilized in a negative pressure room. I have a feeling it wants me to put the hazmat suit on. Which I have, okay. Whole bowel irrigation? What in the actual... No, we don't need to do that. That would be rude. That's interesting. I mean... Do some watering. I mean, his electrolytes look fine. I want to test him for C. diff. He has probably colitis going on of some kind. But I can't prove what kind of acute gastroenteritis. Ah, freak, I hate doing this. Alright, that's not gonna tell me much though, will it? Liver and gallbladder, gallstones, bile duct. Yeah, that's what I thought. Don't do that. Cellulitis, that's what I thought. No. Ultrasound lung. Hold on. Pneumonia. I didn't think it would tell me about pulmonary edema so much as pneumonia. I mean, that's what chest x-ray does really good at. It's just the testing, yeah. Hold on. Entire body shockings. Okay. You know what? We can actually redo circulation now. Still a little soft. Stabilize. We could probably do another bolus of fluids. I'm not sure what this other one would be. Oh, pneumonia. Ha. That's probably it. That might be it. Could be the one. Already got that one selected. Sepsis. Now I can actually do away with one of these. Pneumonia, community acquired. Key respiratory distress. I think you meet sepsis criteria. You got the IV. You don't need an antibiotic. Hold on. What was your lactate? I think about it. Yeah, no. I think we're good. Let's go ahead and hand this off. Why are you making me put 3 different... Okay. COVID-19 sepsis. Hand off. Finish. My interventions were off. What was the other thing? Yeah, like I said, you didn't need the hazmat stuff. Antipyrate. Yeah, I gave him Tylenol. What's the other one? Remdesivir. I actually thought about doing a steroid. But I wasn't sure if that was still being done with that or not. It definitely makes sense too. The Remdesivir. I forgot all about that stupid med. Yeah, Remdesivir would have helped. Is that the biggest thing that I missed? What was the diagnosis? The other 2 diagnoses. Viral pneumonia. With associated myocardial injury and myocardiomyopathy. Where are we? If a patient systemic illness, infiltrates chest X-ray, antibiotic therapy is reasonable, although the cause is viral in this case. The exact cause of the patient's cardiac dysfunction cannot be immediately diagnosed. Your patient has evidence of both direct myocardial injury. I didn't test the troponin. I thought about it for a second, but I was like, everything else seems fine. A depressed cardiac. I didn't do an echo. I didn't think it was warranted at the time because to me, we're in the ER and all we're trying to do is figure it out and stabilize. We figured out what it was. We stabilized, send him up to the floor, and we can run all the other tests later. But I think I did an EKG and it didn't show ischemic changes. I could have checked the LFTs. Yeah, Procal is one of those like, Increased risk of DVT, yeah. Fair enough. See, this is why we do this. This is so I can refresh and learn again, because it's been so long. 69-year-old female with 2 days of intermittent chest pressure, pain, constant for the past 30 minutes, and partially relieved by 1 spray of nitroglycerin. Aha. Chest pain times 2 days, hypertensive. Let's get this started. Okay. First things first, attach monitor. Let's get an IV. Blood pressure and all this looks great. We have chest pain. Immediately EKG. Shock the patient. No ST changes. So we're probably just dealing with acute angina. Like she's responding. Let's go ahead and do the ABCs. Everything's good there. Cards, regular rate. 1/6. Ejection murmur at the... Okay. Just to make sure. Alright, we got that. Can we do... Well, okay. One of the big things that we also should be doing right here is one of these, one of these. Go ahead and check these. Yes, 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 yes. Can do that one. It's kind of, why not? Just throw it in there. Just throw them in there. I want it all. Your talk screen. High blood pressure, high cholesterol, kidney problems, neck issues. Neck issues. Medications do you take at home? Amlodipine, Lasix, Losartan. Okay. Gabapentin. Alright. No drugs found in the system. BMP's mildly elevated. We're going to do a chest x-ray here in just a second. Creatine's mildly elevated. Okay. All the other labs look relatively okay. Definitely no alarm for infection. Other labs, just to knock it out, let's do a quick chest x-ray. Normal. Ultrasound cardiac. Is this the same thing? Is this the echo, right? Cardiac ultrasound. All of that seems to be normal. Alright, well, let's get back into this. I'm not feeling any pain right now. I have had some nausea and sweating with the chest pain. Oh God. Did I do a... Just get a coag panel as well, just... Alright, well... I don't know why I expected it to come back high. D-dimer is fine. Alright, well, we got that. All this other stuff's in there. I almost feel like I need a second IV, but I really don't. Atypical chest pain. Or acute angina. Just might be atypical chest pain. Of course, let's get cards involved. As initial negative troponin, however, that does not fully rule out ACS, and that is because it can take some hours before troponins actually come back. You should get a second troponin before we determine the next step. I'm assuming some time goes by, and we go ahead and get a second troponin, which you should get a set of 3, honestly. And they should be, what, 6-8 hours apart? I think it's 6 hours apart. Where are you? There you are. second test. That's nothing. It's marginally positive. Given the symptoms, there's concern for unstable angina or an early stimuli, you should admit them and see them in consultation. No heparin for now. I was about to say, he's like, usually you're not wanting me to do heparin. I'll see them in consultation. No heparin for now. They probably need a cardiac cath during his admission, but no need to activate the lab right now. All right. Well, we're going to go with atypical chest pain. Unstable angina, I mean. I was going to say, I don't think I have one angina. I want to put angina. Where's the where's it at? Where is it? There it is. All right. We're not going to prep the operating room. We're definitely not discharging to outpatient stress testing. No. But I don't think you need to go to the IC telemetry unit. Yes, please. Thank you. Is there anything else? Blood pressure is mildly elevated. Heart rate's good. We probably will let them handle the blood pressure. 156/89. Yes, it's high, but it's not outrageous. They can look at what medications they want to give. I mean, is there anything I missed on the exam? Just freaking click them all. Read through them here in just a second. So most of these shouldn't really matter too much. No mass, regular rate. Yes, fine. A little bit of ankle edema. Alright, let's do it. It's probably going to tell me I'm not done, but hey, 93%. What's my intervention that I missed? Is it going to say blood pressure? Possible cardiac ischemia. What did you say? Nitro? Oh, wait. Aspirin. Yep, there it is. Aspirin. I should have given aspirin. I forgot all about aspirin. Oh my gosh, the life-saving aspirin is what messed me up. What did I miss on investigation? I sent out for a blood typing screen? Yeah, I didn't think well, this one right here could have been. And yeah, yeah, I was like, I'm just gonna click everything. I went a little click happy with the labs, I admit it. It's like, I want that, not. Cardiac arrest from lobby, CPR, no! Patient will, god dang it. Alright, well, of course, let's IV, monitor, chest compressions, let's go. We got VFib. Let's go ahead and get ready for a shock. Where's all my stuff at? Thank you. Pacers. Place pads for monitoring. I want this on. We're going to go ahead and shock. I've identified this as a VFib. And shocky. Let's go. We got a rhythm. We still need to be doing oxygen though. Bag valve mask. Let's go, guys. Come on. Why are we not bag valve mask? Thank you. Give me some breaths. We are going to be intubating. Position for intubation. Prop into tracheal tube. Suction. Pre-oxygenate, intubate. I could have maybe done the RSI drugs, but she's unconscious. We're in the middle of a code. We've got breath sounds. All right, let's go ahead and get a chest x-ray in here stat. Get that going. All right. We're not going to do any of the sedation medications right now. Do we have a pulse, guys? Tachycardia, irregular pulses are present. Beautiful, guys. Beautiful. Woohoo! Y'all did it. All right, let's go ahead. We are going to go ahead and start normal saline. Let's do... God dang it. What am I missing? There was something else I really wanted to do. None of that. Let's get a second arterial line at least. Procedures. We don't want to do that just yet. We're really pressing some stuff here. Investigation, that's what I'm wanting. Well, first things first. Let's do arterial blood gas, BMP, calciums, CBC, D-dimer, mag, phos, troponin, other labs. I don't know that we need to do that yet. The temperature's already kind of up. I'm thinking her magnesiums are going to be low. Is it almost... Or some of her lab work's going to come back looking crazy, very wonky. Which none of them are. I mean, troponins are up a bit. But I mean, she was just in cardiac arrest. CO2's going to be mildly elevated after coding, more or less. Oh wait, did we even check this? Good position. So what else would have caused it? Bedside test. This is for ischemic lambs and shock. We don't need that. Go ahead and do EKG. AFib with large inferior ST elevations. Beautiful. Okay, we had a heart attack. We need cardiology on board. So we're going to be doing code STEMI. I can take the patient to the cardiac cath lab position whenever you're ready with them. Beautiful. We had a massive MI. Where are you? Cardiovascular. It's not going to be that. Is arrest a thing on here? Myocardial infarction. Choose at least one more. Vasospastic angina. And VFib. I like that. That works for me. Handoff. We are going to be transferring to the cath lab with these two. Just make sure we're kind of relatively stable. Should probably go ahead and push liter saline. Try to help stabilize the blood pressure just a bit right before sending them out. Okay. (90/56). That's not going to be amazing, all right? There's a thing about doing like epi drips at this moment. It's going to cause the blood vessels to constrict, which could worsen a heart attack, and it's also going to make the heart work harder. It's just, blood pressure is relatively okay. I mean, I wouldn't doubt it if I'm supposed to start the epi drip. Is what I'm trying to get at. But the blood pressure is not absolute crap. It's not good. Definitely should be higher. 87. Oh. Well, to be fair, I didn't examine much. Hey, what do you mean nothing on the interventions? I shocked them. That was the biggest intervention. Cardiogenic shock, which would have been put them on like the dobutamine or something like that. What's the other one? The other big one. Dopamine. Aspirin. I thought about doing it, but they're unconscious. What am I going to do? Rectum. Yeah, I figured. Do you want to do that? Heparin. I definitely should have done the heparin. And yes, I should have done that. Be tighter. Yeah. They were already hypotensive. Okay. OG tube. Yeah, I guess so. Norepidrip. For cardiac, after cardiac arrest, because of mixed alpha and beta, dopamine has an increased risk of arrhythmia. See, I've never used dopamine. I think I've seen dopamine used maybe once. Because usually we use something else. Okay. Examinations. Which ones? And perform interventions using the cab. Breathing exam, airway exam. Did I not do any of that? I skipped right over it. I forgot to go back. All right. So this alone really junked down my score. So I actually did fairly well. The heparin I kind of knew, but I was just, which, yes, it should have been done prior to going to the cath lab. 100% I agree with. The rectal aspirin, yes and no. The last thing I'm worried about in the middle of a code is shoving aspirin up somebody's rectum. I probably could have started the propofol, but she looked like she was still out of it, and her blood pressure was a little bit on the soft side. Doesn't mean we shouldn't have sedated her, though. Yes, I'm aware. All right, we're not done, though. I do have to use the bathroom. Hold on. You can change difficulty anytime. What's this? Hard. AI enabled. Medium. I do want this. I'm not trying to redo all my things. Recommend. See, I don't want these here. What's this exactly? No. Take that off. I don't want the real-time feedback. There we go. Save. Beautiful. All right, I'll be right back. Speaking of which, I'm curious. Uh-huh. All right. Anyways, won't be gone long. Okay. We are back. We are back. We are back. Let's see. Let's get this bad boy pulled back up. Over 200 cases. Another random case. Let's go with it. Patient is a walk-in 49-year-old male with burning. What the heck is a SSCP? Moderate severity, no shortness of breath, no distress. What is a SSCP? What am I missing here? It's a male. Alright, let's talk with the patient. He's rubbing his arm. I got this burning chest pain. Okay, burning. Exam. First thing, airway, breathing, circulation. No striders, symmetrical, +2. Head, ears, nose, throat. Let's go ahead and hit all these other ones. No masses, nothing there. And everything there is looking great. Let's look at GU. An abdomen, nothing there. I'm kind of thinking he's just having heartburn, to be honest. Put the monitor on. Everything there looks great. We'll put in an IV just because. Bedside test. Let's go ahead and do an EKG just to rule it out. I'm not expecting much. Normal sinus. We're great. We'll go ahead and do this. We'll do a Magnifos and a troponin. I don't think we need to do a urinalysis just yet. Everything here appears to be coming out okay. I'm pretty sure he's... keeps reaching for his arm and his chest. Nope, just in the middle of my chest. Any other symptoms? No, just a little chest pain. Alright, I have an idea on what's going on. I may have been wrong with what I initially thought. High blood pressure. Blood pressure's mildly elevated. I'm not worried about that. Blood pressure medications. Alcohol or drug use. Drink a few times a week, but no drugs. Okay, well, that tells us some things. Let's go ahead and do these real fast. I don't think we really need to do a lactate. We'll do it. I don't think we need it. Did I already ask about allergies? I did not. Let's go ahead and do an ethanol level. I don't expect it to come back really all that high or anything. Alright, well, I gotta do that. Any allergies? Not that I know of. Huh. Well, that looks great. Let's do an ultrasound of his abdomen. Gallbladder is normal. Negative Murphy's. Okay. I mean, heartburn. That's what we got. Is that going to be under miscellaneous? Oh. I'm thinking it's GI, honestly. Let's go ahead and consult cards just to be safe. I have a feeling I'm going to get screamed at by cards. Not sure why they call it. Recommend EKG if they have chest pain. Yeah, already done. This is probably going to let me too. Abdominal examination and look for peritoneal signs. Have I already done that? Everything here is fine. I guess just go through the rest of these. I'm not seeing anything though. Yeah. Wait, did I do a chest x-ray? I did not. Shoot. No, nothing. Nothing at all. Uh-huh. I don't see most of this other stuff being a thing. Let's go ahead and check that. Just because, I guess. And I mean, I've already done just about everything on him that I need to do. Yeah, okay. I'm pretty sure we're good. All right. Well, shoot. Everything's looking great. I'm kind of at a loss of things. Burning sensation. Hold on. Spicy meal today. God damn it. Yes, that is all it is. GERD. That's what you got, sir, is GERD. Go home. Is there anything I can get for GERD? I was looking for that earlier. I didn't see anything immediately. Gastrointestinal. There we are. Maybe. Do we have something else? We'll give this, actually. There we are. Honestly, do we even need to do that? Let's start with this. Seven out of 10. God, for God's sakes. Okay. Well, what if I do... I don't want to give him too much. Let's start with this. Treat the pain. Okay, pain's treated. And otherwise... Let's do this and send him out. Communication. Oh, unnecessary consult card. I mean, I figured it was. Intervention. What's the other one I missed? Morphine. He was in pain. Yeah, I was actually looking at basically all of these. There was Tom's. I didn't see it. That's the one I was originally looking for. And that would have fixed his... okay. Yes, yes, let's go. Next case, bring it on. Patient is a walk-in. 58-year-old male presents with shortness of breath times 2 weeks, increasing dyspnea, and on exertion, hypoxic at triage to resuscitation phase. All right. 58 with shortness of breath over 2 weeks with, okay, so this sounds cardiac for sure. So first thing we're going to be doing is this right here. Oxygen's a little bit on the low side. Let's go ahead and put him just on an Azacan and see if we can get it up to 95%. I don't know what his baseline is. Just gonna get into it. I had a collapsed lung. High blood pressure. God dang it. Okay, well, there goes my theory. Chest x-ray. That's a really big looking heart. I'm just saying. Okay. High blood pressure, and that's about it. Okay. Lisinopril. Feel short of breath, especially at night, and my vision gets blurry sometimes. I'm also feeling anxious. Anxious, you say? Well, let's go ahead and do an EKG. I do want an ABG just because. Magenfoss, troponin. I don't think I need this yet. No striders. Everything here is fine. That's fine. That's fine. Decreased chest wall excursion with deep aspiration. Aha. Bicarb's elevated. So this has been going on for a while, which makes sense. His CO2 is indeed a little on the high side. Chest x-ray didn't show anything though, right? Normal lung field, no evidence of anything else. Alright, let's do... Oh, he needs to work on some deep breathing. We don't have any wheezing though. Let's go ahead and do this then. Let's hold off on that actually. Oh snap! Hold up! I just noticed his oxygen's dipping down. I didn't fix nothing. Ruh-roh. He's coming up slow. No, he's not. Oh, he's about to code, isn't he? What just happened? He is breathing 30 minutes. Alright, stop. Okay. Alright. Let's just tell me how much oxygen he's on. Peep's a 3. Come on, raise that peep up. Doesn't really talk about that too much, does it? I didn't even realize I could click on some of this other stuff. Nice. Hold up. Oh, can we turn the TV on? I'm getting distracted. Alright. Let's get with Palm. I need their help because I'm lost on what else I should be doing here. Not sure why you recommended chest x-ray if you're concerned with the patient's result. I did. It didn't show anything. Oh, yeah. Okay. Well, you're a lot of help, Palm. Respiratory therapist. So we're just gonna go with respiratory failure, huh? Did I already... I did. And he didn't look great. I guess I should have noticed that that was 70 at the time. Alright, well, let's go ahead and do this. My guy, we're gonna do some RSI on you. Intubation. Position for intubation. Repair. Alright. We are going to do... Not you. Accommodate. Oh, wow. I never... Okay. I guess let me put the first one in. Okay. Now. Accommodate. Rock. Suction. Reoxygenate. Rapid sequence intubation. I don't know why he's in respiratory failure, though. That's the big problem. I have literally nothing that I can do there. But otherwise, let's go ahead and get him started on... the probe, infusion... blood pressure. It should help out with some of the heart rate as well. Oh, perform. Alright, blood pressure's still looking fabulous at the moment. I guess this white count came back normal. That's one of the big things that I'm just like, what's going on here? Alright, respiratory. I don't know what else to call it. Admit to ICU. Take him. Figure it out for me. I don't know. What was it? What was it? MG? Myasthenia gravis? Is that what this was? MG. makes sense. That's why, okay. Wow. Okay. Well, that makes a lot more sense. He still would have been intubated though. And okay. IVIG. And steroids. Makes a lot of sense. I could have done IV steroids in there too. I wasn't thinking MG at all. Alright. Anyways. Patient is a walk-in 41-year-old male with fever, chills, weakness times 2 weeks. Temp is 1.5 this AM. Other than fever, no COVID symptoms or exposure to nice cough or shortness of breath. So he does have a fever. 41-year-old male though. First things first, let's go ahead and attach the monitor and perform our ABCs. Dash Trader, all that stuff's good. Cards and poem. Let's talk with the patient. Nothing going on there. All right, talk with the patient. What brings you in? Ooh. I've been having fever and feeling really run down. Nothing major's happened to me. Hasn't taken any medications. No, don't. I don't use drugs and I only drink alcohol rarely. My muscle and joints ache a lot. Okay. Sounds like he's definitely got something going on that's more on the infectious side of things. I guess cytokine storm. Let's look at the other stuff. Oh, that's good. That's good. Oh. Seems like what we're looking for is in the belly. Let's go ahead and do some of our initial lab tests. We really don't need an EKG. I will get a baseline EKG just because I can. BMP. I don't think I need any of that. I definitely want that and that. Why not? I don't think I need any of that. I'll get this. BRP, CK. We'll hold off on the CK for now, actually. Why not? Normal sinus. Wasn't really too concerned about that one. Oh! Hello. That tells me a lot. Hemoglobin's low too. Hold up. His platelets are low. Okay. Okay, we're starting to get a picture. Alright, first things first. let's do this. Or actually, let's... No, God, get out of here. This. I want this. Alright, well, I'm going to insert that IV. Just say yes, a pain. We probably will. Awesome. Awesome. We are probably going to want to go ahead and actually get a blood type and screen, because he does appear to have some other things going on there. Oh, positive. Of course he is. And we're going to consult GI. Really? Well, you weren't very helpful.
Dr. Febowitz, please report stat to room 10. Dr. Febowitz to room 10.
Thank you. That makes sense. Parasitemia. Interesting. Now, if I consult you again, are you going to get mad and say the same thing? Looks like the cause is infection. For further treatment recommended, I'd suggest you reach out to our ID consult. Sounds good to I. Well, if that's the case, we better go ahead and at least get some cultures. Because that's one of the first things they're going to ask. Well, did you get any cultures? Oh, yeah, we already did. And for it to be effect and everything else, I don't suspect it being most of this other stuff. I don't know that we did a chest x-ray, did we? But nothing sounded crazy here. Okay. Let's go ahead and consult infectious disease. A 2-drug reagent is usually used to treat this condition. I prefer the treatment with Adovacone and azithromycin. Okay. Whatever you say, Doc. Alright, we've got these done.
Code STEMI, cath lab activation. Code STEMI, cath lab activation.
Babesiosis. No, hold on. Did my skin not show? No rashes. That is what I'm seeing, right? That's where we're at. That would have been on here. 0.8%. Yeah. Could be wrong, but let's see. Hey! Oh, yeah, what am I missing? Oh, because I consulted them. Fair enough. You know what? I'm cool with that, though. What's my other interventions that I missed? 2 of 3. He wasn't running a fever! No, god damn it. That's not what I meant to do. He was 37%, right? That's what it said. He wasn't running a fever. Why would I give him an antipyretic? Plus, his liver was hurting. Ah, that's so annoying. I'm calling BS right now. Alright, where are we at with this? Patient presents to the ED via wheelchair from her oncologist office. 46-year-old female with breast cancer presenting from her oncologist office. Patient called the office earlier today to report left leg pain and swelling. Her doctor asked her to come in for an evaluation. That leg looks pretty bad, actually. Holy crap, look at the color of that thing. Anyways. Oh, oncologist with breast cancer. That's sad. Her doctor asked her to come in for evaluation on examination deck. Doctor referred her directly to the AR. None of the other stuff. She doesn't look happy. I guess I wouldn't either if my leg looked like that. We're definitely going to go ahead and get this started. All of this looks fine. Examination, ABCs, just to double check everything. What brought you in today? Look, my leg hurts really bad. It's swollen and discolored. Past medical history. Breast cancer, mild hypertension, and kidney problems. I am on chemotherapy and take some vitamins. You take the vitamins, huh? Okay. Any allergies? Penicillins. Okay, well, we're going to stay away from the penicillins. Alright, well, obviously we got something going on with the skin. Left lower extremity is bluish in color. Basically meaning it is dead. We're going to go ahead and check this. Regular rhythms. We'll go ahead and do these just because we can. Everything's good. Everything's good. Very faint Doppler pulse in the left lower extremity, +2. Okay. I better at least check that one. No wheezing or rhonchi. Bedside test, chest. I want an ultrasound. A Doppler. Where's Doppler? Do we have Doppler? Where's the Doppler? Can I actually just do that? Other line. We might as well go ahead and get these out of the way. Let's go ahead. This. That. That. I could have sworn Doppler was a thing, but I guess not. Oh, the D-dimer's outrageous. Well, I see a heparin drip getting started. There's abnormal venous enhancement. Okay, well, I can already tell you basically right now. One of the first ones is going to be vascular. I will come see the patient immediately and I will call the intravenous radiologist if needed. So either be on that or thrombolysis ASAP. Yeah, I mean, I figured that much. The question is, do you want me to give something, or are you going to take her? Let's go ahead and place a second access line just in case.
Dr. Febowitz, please report stat to room 10. Dr. Febowitz to room 10.
Cardiovascular. It's none of those. Oh, trauma vascular. There we go. Is that what I'm looking for? Is a DVT?
Code blue, hospital lobby.
I think it is. Yeah. A really bad one, huh? One more diagnoses. Well, not gonna be any of that. What is this? There we go. Peripheral arterial occlusion. There we go.
Code stroke, room 1.
All right, with that,
Room 1.
oh, let's see. Let's consult vascular one more time. They're probably going to scream at me because I'm doing the same thing. All right, it's just the same thing. All right, whatever. I don't think there's anybody else I really need to get a hold of. Maybe Hemok.
Code stroke, room 1.
No, not everything's about leukemia, Hemok. I'm sorry. As much as you'd love it to be. Prep for this. That is what this showed, right? Let me just make sure. Check out that CT again. Normal arterial enhancement of the left lower extremity. There is abnormal venous enhancement throughout the extremity.
Febowitz to room 10.
So it's not an arterial. It's all venous. Actually, right? That's what that's saying? This is the one where there's something actually, there's blood in the... Hold on.
Code blue, hospital lobby.
Blood counts are fine, right? Okay. The only other imaging I can think of. Ultrasound of the lower extremities. DVT, left lower, normal color flow, left femoral, popliteal. Echogenic material was noted within the left common femoral vein. Distally to the popliteal vein, and the veins were non-compressible, so completely occluded. That's the veins, but not a peripheral arterial occlusion. But that was saying that there was nothing there for the arteries.
Dr. Febowitz to room 10.
I don't know what else it would be. It's gotta be that. It's gotta be, right? None of these other things are gonna... maybe. Pseudo gout. No. These are things that they're not concerned about. Dermatol. Yeah, no, it's not any of that.
Dr. Bakir, hospital is holding on attention 3500.
Yeah, I think that's about as all I can do. I could be wrong on one of the diagnoses because I'm not 100% sure. But I would say this so far, 67%. See, what else was, what was the other one? I did an ultrasound, yeah. Giving her elevated creatinine. Additional images should not be ordered unless risk and benefits were... Okay. Her kidneys were probably shot too. Is she acute renal failure as well? Plagmacia cerula dolens, a rare but severe consequence of extensive DVT. Uh-huh. Never heard of that. Ischemic pain and cyanosis. Yeah, I mean, that was clearly all there. That's a very interesting. Blistering following cyanosis, yeah. Occurs commonly in women 5th to 6th decades of life. Rapid diagnose, restore blood flow. Ultrasound. Avoid radiation. Does not require IV contrast. So my CT that I did was completely unnecessary. Findings include non-compressible veins, increase vein diameter, and increase echogenic within the lumen. CT and MRI venography can be performed if necessary, but an ultrasound and clinical presentation are generally adequate. Okay. Unfractionated heparin should be initiated immediately. Or you could do Lovenox with the low molecular weight heparin, giving light. No, this says don't do that. This patient's renal insufficiency wasn't good. Okay. Unfractionated heparin is preferred over low weight molecular. Okay. An additional advantage of using unfractionated heparin is that it can be discontinued if needed. Therapy. Okay. Early consultation. Patient, a large clot burden, and evidence of vascular compromise from surgical intervention is typically preferred. Huh. Blood examination. Okay. I'm sorry. Investigation. Yeah, damn it. CTA was unnecessary. Yeah, I got okay. It was on the right track though. The one time I didn't treat your pain. All right. Anyways, I think that that's gonna be good for now. How did I hear about y'all? I don't know. Just kind of browsed. All right, I think that's it for me tonight. So if you liked the video, like it. If you dislike it, hit that dislike button. If you want to see whenever I go live in the future, post future content, hit the subscribe button. Make sure it's that notification bell turned on. That way you are notified of whenever I go live or post future content. Otherwise, y'all have a wonderful day or night, depending on where you're watching at in the world. And until next time, I say goodbye.